When we talk about staging in lung cancer, what do we actually mean? My name is Dr. James Wilson. I'm a clinical oncologist in London, and I want to break this down so that it's really clear so that you understand what's happening and why we're requesting all the investigations that you need before we make a treatment recommendation. So when people ask me about staging, they often ask me, is it stage 1, 2, 3 or 4? Now, we need to break that down a little bit because stage 1, 2, 3 and 4 are actually prognostic groupings. That means predictors of how well a patient's going to do, and that's based on the TNM staging system. So let's talk about that first. All that staging is telling us about the primary tumour, the lung cancer, and how far it's spread. So let's start with the TNM system. In the TNM system, T stands for tumour. Think about this as telling us how big the tumour is where it started in the lung. It might be small and self-contained, or it might be larger or growing into neighbouring structures. Smaller tumours are lower numbers, T1. Larger tumours over 7 centimetres or tumours that are growing into important structures, they get a higher number, so T4. N stands for nodes. We all have lymph nodes all over our body, the sort of kidney bean shaped things that filter the fluid as it travels through our body. It's part of your immune system, but it is somewhere that cancer cells can get trapped. If there are no lymph nodes involved, that's an N0. Then depending on which lymph nodes are involved, you'll get a score of N1, 2 or 3. N1 nodes are very close to the tumour, N3 are quite far from the tumour. Obviously, if your cancer's learned how to spread to the lymph nodes, that puts you in a slightly higher risk group. M stands for metastasis. Has the lung cancer learned how to spread from where it started in the lung through the circulation to other parts of the body like the liver or the bones? Looking at your scans and other information about you, you'll get a score for T, a score for N and a score for M. We then combine all that information and fit you into those prognostic groups or those predictive groups that we talked about earlier. So you'll be assigned to a stage 1, 2, 3 or 4. Why do we do this? Well, it's all about getting you to treatment. I know that treatment for a stage 1 cancer is much different to treatment to a stage 4 cancer. We'll talk about that in future videos in the series, but broadly speaking, early stage disease, we aim at local treatments primarily, and as you progress through the stage numbers, you're more likely to need a treatment that gets all over the body. Let me give you an example. If you have a 1 centimetre tumour in your lung, it hasn't spread to the lymph nodes, and it hasn't spread through the body, you have a T1, N0, M0 lung cancer. That's a stage 1 tumour, and for most people in that situation, you'd be offered curative treatment. As another example, if you have a T3, N2, M1C lung cancer, that means the cancer's learned how to spread through the body. So you don't want a treatment that just focuses on the chest. You need a treatment that's going to go all over the body to capture the cancer wherever it is. Now, in that situation, a stage 4 cancer, traditionally treatment's always been about shrinking, controlling, containing the cancer for as long as possible, but unfortunately, usually not offering a cure. Now, something that people often get confused about is staging versus grading. Staging tells you how far the cancer is spread through the body. Grading tells you what the cancer looks like when you look at it down a microscope, and it gives us a clue as to how aggressive your cancer is behaving. Certain types of non-small cell lung cancer can be graded from 1 to 3. Grade 1 means it's well differentiated, which means it looks very much like the normal lung tissue from which the cancer arose. Grade 3 tumours are poorly differentiated and they look very abnormal and very aggressive under the microscope. Adenocarcinomas, a type of non-small cell lung cancer, tend to be described on their appearance rather than given a grade number. We consider all small cell lung cancers to be high grade. We don't usually use the grade of the cancer to make treatment decisions, it's more the stage that we use, but increasingly we're using genomic signatures from your individual cancer to make treatment recommendations rather than the grade. So it's important you have a biopsy of some cancer tissue so we can do that genomic profiling. So in summary, staging is about location in the body, grading is about what the cancer looks like under the microscope and how aggressive it's behaving. So why are we doing all of this? Well, it's all about getting you to treatment. We need to stage your cancer so we can give you the best treatment for you. If you have a stage 1 cancer, it's likely that we're going to recommend something like surgery or stereotactic radiotherapy with the aim of curing you. As we progress in stage 2 and 3, you're likely to need a combination of treatments because while we're still aiming at a cure for many people with stage 2 and 3 cancer, we know that some additional treatment is needed as an insurance policy to stop it coming back or to make the treatment that we're giving, such as radiotherapy, work better. Stage 4 treatments are usually treatments that work throughout the body, things like immunotherapy or targeted therapies. Now remember, staging isn't about prediction, it's about getting you to the right treatment. It helps us act quickly, make accurate decisions and get you on the right treatment to get the best results for you. In this series of videos, I'm going to walk through each of those stages of cancer, stages 1, 2, 3 and 4, and we're going to talk about what your treatment might look like depending on the stage of cancer that you have. Please remember, there's always something that can be done, and certainly you shouldn't be living with troublesome symptoms. Always ask your doctor if you're concerned about something. In the next video, we're going to talk about stage 1 lung cancer. I'm Dr. James Wilson. Let's make cancer less confusing.